Liebe Kolleginnen und Kollegen, liebe Freunde des Amboss Studientelegramms. Marcus at Home welcomes Professor Ole Frobert in Örebro, Sweden, with whom we would like to discuss the importance of flu vaccination in patients at high cardiovascular risk. Ole, thanks a lot for taking the time and for being our guest today.
Thank you so much for having me.
Dr. Frobert is Professor of Cardiology at Örebro University Hospital. He is an interventional cardiologist who is eager to look outside the box and to test innovative approaches to improve the cardiovascular outcome of our patients. This includes not only conventional cardiovascular drugs and devices, but novel approaches that may better the outcome of our patients. And in this context, he has just 2 weeks ago, I think even at the same time of the day, presented his IAMI study in which he compared the cardiovascular and overall outcome of patients with acute myocardial infarction who were randomized to receive either a flu shot or a placebo vaccination. We briefly discussed this study at our German language post-ESC meeting 10 days ago, but we think that this study is so important for doctors inside and outside the field of cardiology that it's really a privilege to have the main author with us today to ask him some more detailed questions than the ones we addressed so far. So this may become the first of a mini-series of some videos and talks on the most important studies from this year's ESC meeting for colleagues inside and outside the field of cardiology. My co-moderators today are Professor Barbara Gärtner from Homburg University Medical Center, who is specialized in the field of microbiology and who for many years is leading the fight for a broader acceptance of flu shots in the Saarland, both among healthcare workers and in the general population. And Anja Scheuer, who is the technical director of Marcus at Home and who is going to become a doctor in internal medicine and nephrology. My name is Gunnar Heine. I'm a nephrologist at Agaplesion Markus Krankenhaus. So Ole, if okay for you, I would suggest that Barbara Gärtner will take us into this issue. Winter is coming. This is the time of year where we usually remind our patients to see their GP and to ask them for their annual flu shot. This year, everybody talks about COVID-19 vaccination, first vaccination, second vaccination, third vaccination. So let us talk about flu shots this year. So after a winter in which flu was virtually absent in the Northern Hemisphere, why should we remind our patients to go for their annual shot? Should we care about flu at all this year?
So I hope we hear in the following minutes a lot about why it is important to vaccinate against flu. Flu is the most important infectious disease in the Western world, with by far the highest mortality and morbidity. And we often do not concentrate really on this high mortality, especially in patients with underlying diseases, with heart diseases, with lung diseases, different other diseases. So it is really the most important disease, and I think one of the most neglected diseases in this context. And congratulations to this great study. I hope this helps us a lot to convince people that vaccination against flu is important, not only to overcome an influenza-like illness, but for other really serious adverse events as well. So it is really courageous to start a study on influenza vaccination because there are so many obstacles for such a study. And I'm really impressed that you did that. Next to some we already know in advance, possibly a high vaccination coverage in your population. There are a lot of unpredictable factors for such a study, and one is the epidemiology. And this can be very different from year to year, from area to area. And in some seasons, we have an activity of around 2 to 5% of the population who get flu. In others, there's almost nothing. In some years, we have in Germany mortality of 40,000, 50,000 persons in some years, almost nothing. So this comes close to COVID in the end. And some other obstacles are the match between the virus and between the wild type virus and the vaccine virus. And in some seasons, we have a vaccine effectiveness which is around 50%. And this sounds to be a low number, but in the end, it is the highest we usually get. In some years, it is less than 20%. And vaccine effectiveness correlates with the subtypes. For H1 and B strains, it is usually higher. For H3, it is really, really critical and sometimes really less than 10%. And in the end, you have a well-planned study and you get no effects because the virus is not in the mood this year. So the only way to overcome this is to cover many different seasons. And this again results in new problems. For example, the recommendations for the vaccinations change over time. And we had the change from the Trivalent to the Quadrivalent vaccine. We have in Germany this year for the first time the recommendation of a high dose vaccine for patients over 60. And in other countries, we have adjuvanted vaccines and recombinant vaccines recommended as well. So we have a bunch of different vaccines which might have a different vaccine effectiveness, probably a different vaccine effectiveness on cardiovascular risks as well. And in the end, even less foreseeable, you get a pandemic and virus circulation stops like we saw it last year. And I don't know what we really have to expect this winter, but it's always interesting to have a look on Australia because they have their season now and they have still no circulation in Australia at the moment. I'm not really sure if we can adapt this result for our winter season because there might be some changing factors as well. For example, due to the vaccination against COVID, the lockdown measurements are stopped and people don't wear masks anymore. And this can result in an increase. And I was very happy to see that the COVID pandemic stopped the influenza circulation because we saw what we have to do. And keeping distance, wearing masks, these are so important factors. Probably they are more effective in preventing influenza than in preventing COVID. So I hope that we keep on doing these measurements in the future, at least in the hospital, that we treat our patients only with masks, even when COVID is over. So I'm really impressed that you initiated this study and even more impressed that you finished it with these significant results.
Thank you so much for that overview. I would like to start by asking Dr. Frobert some questions about the IAMI trial. First of all, how come you as a cardiologist initiated a randomized controlled trial on vaccination? What was the rationale behind it?
The rationale was very, very objective because I received a flu shot myself, and that was in 2013, and I had a slight fever. And you know, a man flu is a very serious disease. I was lying on the couch, and the family didn't feel sorry for me, so instead I Googled, and I found out, these two perhaps most prevalent diseases in the world, cardiovascular disease and influenza, they have something in common. And that has been known since the 1930s, that many patients dying from flu, when you do an autopsy, you will see that quite a few of them died from myocardial infarction and many from heart failure also. That was the idea. Then I wondered, has there been conducted any studies? And there were very few studies. There were lots of observational studies. There were hundreds, and there were so many reviews and meta-analyses. And then there were only 3 studies published in full, small single set of studies in countries like Argentina, Poland, and Thailand. And I thought, well, if this is not enough, we need to do a large study.
Can you tell us a little bit about IAMI? What was the study about? Who was included and what did you find out?
So the overall purpose of the study, of course, was to determine whether influenza vaccination improves clinical outcomes in patients with a myocardial infarction. And already at this point, influenza vaccination is carrying quite a high level of evidence. So it's a class 1 level of evidence B in both American and European guidelines. So patients with cardiovascular disease should have a yearly flu shot. But when you look at the European data and the yearly data from the EU on this, it's by average between 50 and 60% of these risk patients that get a flu shot. And part of that is because whose responsibility is it? Is it the patient's responsibility or is it the primary care physician? So by doing a study where we enroll patients at hospital within a short time, and in this study only 72 hours after a myocardial infarction, we could also see, is it safe to give it and does it work? So the whole idea was to only take patients with a recent myocardial infarction and then ask them if they were willing to be randomized in the study with influenza vaccine or placebo before leaving hospital. And then, because it was already kind of a semi-guideline, it was a recommendation, we excluded patients who had already received influenza vaccination during that particular season, and also if patients had planned for a vaccination. And we got that approved. It was borderline because it was questioned in many ethical committees. But we could argue that if these patients are not in the study, none of them will have the vaccine. And if they are part of the study, half of them will. So that helped. And then it was not easy. The study was difficult to get financing. We got some financing from high-profile local foundations in Scandinavia, but not the very big ones. So that part was also a challenge. And then we started with very little money, and then along the way, we got the funding. But despite quite broad inclusion criteria, it was difficult to recruit patients. So we broadened the study outside of Scandinavia and ended up with 8 countries. So Denmark, Norway, Sweden, Latvia, and the Scottish part of Great Britain, and Czech Republic, Australia, and in the end, even Bangladesh. And then we enrolled patients over 4 influenza seasons. And it's also a challenge to conduct a study where you had to stop and start. But we could only provide vaccine because they run out during the influenza seasons. And we didn't, during the planning phase, didn't consider that it would work outside of seasons. Perhaps it does, but so we didn't test that. And then after 4 seasons and 2,571 patients enrolled, we had planned for 4,400. Then came the pandemic, and the Data Safety and Monitoring Board recommended holding the study because they expected influenza illness to go down in societies. And as Barbara said, it did. But also that patients would encounter COVID-19, and therefore it would be difficult to interpret the results. And then our findings. Our primary outcome measure was a composite endpoint. And because it was conceived as a study in patients that were treated invasively, it had a color from that. So it was all-cause death, myocardial infarction, and stent thrombosis, which is not really a flu endpoint, but because influenza is also activating the coagulation cascade and activates platelets, we thought it was reasonable to add it, and it's easy to measure. And then we have secondary endpoints of all-cause death, cardiovascular death, and myocardial infarction that we were allowed to test for if the primary composite endpoint was positive or significant. And it was. So after 4 years and after, unfortunately, the stopping of the trial, with a little bit more than 2,500 patients. The primary endpoint occurred in 67 participants in the influenza vaccine group and 91 in the in the placebo group. And that translated into a reduction of the primary endpoint of 28% and a p-value of 0.04. This meant that we were allowed to test for our key secondary endpoints, and both death and cardiovascular death were reduced by 41%, which is, in our world, huge effect size. Myocardial infarction did not differ statistically between groups, and you might wonder why. And also, we did also, but what has been seen even in the most recent meta-analysis, it's the same. There's a borderline finding. We cannot really explain it. Perhaps influenza vaccination protects against the catastrophic events like sudden death, large thrombosis, but we're speculating here. We don't know. What we also saw was that influenza vaccine is safe. So except for injection site local reactions, there were no differences in side effects between groups.
You already mentioned that the countries that participated were both in the northern and the southern hemisphere, and you also included Bangladesh, which has a tropical climate. Is there even something like a flu season in Bangladesh, and did you see any subgroup analyses of those countries?
Yeah, there is a flu season in Bangladesh. It usually starts in May, June. So influenza-wise, even though it's in the northern hemisphere, it is a southern hemisphere influenza country. And usually influenza there is bipolar, so it goes up and down and up again. I don't know exactly why. But what we saw from the patients in Bangladesh was that the hazard ratio for the primary outcome was exactly the same as we saw, for example, in Sweden. So there was nothing peculiar about Bangladesh, and these were very, very professional colleagues to work with. So we were very satisfied with their participation. And also, of course, we tested for interaction for hemisphere, even for sites, even that was not pre-specified, but we did it anyway. And the test for interaction was not significant. So season or country or hemisphere or sex or previous MI or diabetes, there was nothing. So it was a very uniform effect.
And you started out with the Trivalent vaccine and then later switched to the Quadrivalent vaccine. Why did you change?
Because when we started the first year, the Trivalent was the standard. And then it changed next year, so we changed as well. We couldn't choose to stay on the Trivalent later on. It wouldn't make sense, and we didn't have the Quadrivalent for the first season.
Why is it especially during the early months after MI that vaccination is most effective, and why are patients most vulnerable during that phase?
If we take the last point first, we know that the highest risk for a myocardial infarction is in the year after you just had one. So that's the highest risk group you can find. And then why influenza vaccine works so early, because what we saw in the study was that the event curves began separating within the first 1 to 2 weeks. And that's strange, because it's very difficult to imagine that you will have a protective effect from vaccination that early. But there have been a number of studies, experimental studies, small studies in humans and also in animals, showing that perhaps there's something more to influenza vaccine, and only to that vaccine amongst many other vaccines. And for example, it's been shown in animal models that influenza vaccine stabilizes plaques. And then this year, while we were writing our manuscript and looking at the data, there came a very elegant study from the US where patients awaiting coronary artery bypass operation, only 30 patients, but half of them were randomized to influenza vaccination in the week before their operation, and half had placebo. And they saw that inflammatory markers in the vaccinated patients were about half, and also troponins were halved in the vaccinated. So there is something more here, but we cannot, because we just did a study, we cannot do anything else than speculate and let others do the basic research needed here. But there's something more, a pleiotropic effect, I'm quite convinced.
So it might be rather the vaccine itself than the prevention of the disease that is causing the...
Or both is my guess.
And as a last question from my side, we did always see twice as many stent thromboses in the vaccine group. Was that just play of chance?
Yeah, and it was not statistically significant, and there were so few, I think it was 6 versus 3, and it was down on the very long list of other secondary endpoints. I wouldn't put too much in it, but again, we display all our results honestly and provide the p-values for people to see. There will also a trend towards more hospitalizations for heart failure in the vaccinated group, but that's by definition a very soft variable. Death, everybody knows what that is. Hospitalization for heart failure, maybe it's up to the doctor to say, oh, it was heart failure, or was it something else? Again, and it was borderline. So I don't think we should put too much in it. Of course, we will also combine our data with other studies and see if there is something more there.
I would like to come back once again to the idea behind the results. So you said there may be direct effects which do not really go back to a lesser risk of infection, but may be driven by some anti-inflammatory effects of the vaccine itself. But if I got your study right, you saw a larger effect and larger protection in those years in which the flu vaccine was more efficient in your country. So might be that both actually apply, so that you would both have protection against the virus and maybe some other effects. Did I get it right?
Yeah, that's correct. Again, the test for interaction for influenza season was not statistically significant, but when you look at the graphs, there were 2 seasons where very, very pronounced effect and 2 seasons where it's close to neutral. So yes, both.
And the patients were followed for 1 year, but as the study started some years earlier, are you planning to look for long-term effects, some long-term outcome, or did you really decide to stop after year 1? Because surely the main effect may also apply to this first year.
We in Scandinavia, we have registries. So in Denmark and Sweden, we can look beyond 1 year, but we don't know if these patients actually received another flu shot. Still, it would be interesting. But with the budget we had, we didn't have the possibility to revaccinate for the next season or give them placebo again, if that was what they were randomized to. So this is what we know. It's 1 year. And what we see after that is rather speculative, I would say, what conclusions you can draw.
All right. One other issue, you co-authored last year a JACC review in the field of flu vaccination, where you listed 3 ongoing trials. So surely the IAMI trial, 2 other trials, one of which is rather a comparison between 2 different types of vaccine, if I got it right, but there's at least 1 other large trial ongoing. Would you have any information when we may expect data from that second large trial?
Yeah, the one trial was already published. That was the INVESTED trial running in parallel with our trial, mostly in the US and Canada. And they tested standard dose versus high dose vaccine. But the study was neutral. And the patients they recruited were about 40% had myocardial infarction, but that was within the last year, and the rest had heart failure. So it was mixed, and maybe the effect from adding high dose is so little, so you don't see anything. That was what the authors and the editorials tried to explain the negative findings with, or neutral findings. And then there is one ongoing study called IV, IVVE, and that's mostly in patients with heart failure. Of course, you would have heart failure from ischemic heart disease, and I'm not sure about the status of that one.
And are you planning, or is everybody else planning to do a similar trial in the general population? Because surely it would be very interesting to see whether this large protection is mainly seen in those high-risk patients, or whether that may be transferred also to, say, elderly patients throughout the population. Are you aware of anybody doing this kind of trial?
Not within influenza vaccination in general. And I think after this trial in particular, a placebo-controlled trial will never be allowed again. And that's, of course, a shame from a scientific perspective, but I think we will have to act on what we have here. I would like personally to do a study out of season, but that's not uncomplicated because influenza vaccines expire. So if we can convince anybody to produce vaccines for use in a study only, it's borderline. But it would be so interesting to see, does it work off season? And then we should give it all year, but it will not be.
Yeah. So maybe some final questions to both experts, actually to Ole and to Barbara. So the first issue which comes to our mind when reading your paper, when also hearing the story behind it, that it was yourself who fell ill and who came to the idea. Why is the uptake, the acceptance of flu vaccination so rather low when we see that we got around about 60% or even more acceptance of COVID-19 vaccination within 1 year or half a year in Germany? I'm not aware of the exact figures in Sweden. I guess they are even somewhat higher. Barbara, with all your efforts in this field, why have we been up to now so rather, well, less successful with flu vaccination?
Yes, the people do not feel that they are at risk. And a risk that that is known to us. We deal with influenza or flu-like diseases our whole life. So it is a common risk for us, and risks that are everywhere all the time. In this case, we do not recognize it as a risk. And I hope a little bit that the COVID-19 pandemic helps us to get the flu on the screen again, because in the beginning, the people compared COVID with flu only to say it is not important, COVID. Now they notice that it is different, that COVID is important. And when we now compare COVID with flu, we probably make people more aware of the risk of influenza.
So when we look back to last year, when we were already in the middle of the pandemic, were people more willing or less willing to go for their flu shots? I don't know the figures from last year, actually.
Yes, they were more willing to be vaccinated. But we had no influenza, so no one made the experience that it protected. And we have sometimes, for example, in the influenza pandemic time, 10 years ago, 12 years ago, we had a high vaccination coverage of the pandemic vaccine. And the next years, the vaccination coverage was clearly reduced.
So I'm really positive that Ole's results will help us to convince our patients when talking to them that they should not just go for the statins, which is difficult by itself, not only for the antihypertensive drugs, but they should also go for the annual flu shots. And I think the figures and the Kaplan-Meier curves are so convincing that it might be really helpful to show them, at least to those patients who are able to understand the meaning behind it. I would have one other speculation. So you did all once in a year vaccination. Surely the study was limited to 12 months, as you told us. Might we expect even larger effects if we would go really for annual vaccinations in those people who have not yet received any vaccination? Surely this is again speculation, but are there any ideas behind it that this might be even more protective than the design chosen in your study?
Yes, I think people, of course, should have their annual flu shot if they have cardiovascular disease or even risk of that. But what we saw, and what also has been seen in the very meticulous recent meta-analysis, is that you have the largest effect in the patients at highest risk. And that's perhaps also why our study was so very positive. It was this early in after an acute event, and there we saw this higher effect, which was in line and matched previous experiences. So that's where you can get the most value for money, I think.
May I have a question as well? If you compare the effect of the vaccination to other effects in the prevention, what is the size of the effect?
It's too good to be true. And that means that the number needed to treat to save one life is 50. And therefore, what now Gunnar asked me if we are planning anything else. We have these very good registries in Sweden, and now some of our hospitals, including mine, will start offering vaccine to patients after an MI in hospital. And now we will add this little variable in our registries if the patient received vaccination. And perhaps then we can learn if it also works in a real world scenario. But it was a huge effect size. And of course, one wonders, could they make that? It's such a small study. But again, it's just what the others found.
So as you discussed that at least part of these effects are not really driven by protection against flu, but by some, say, anti-inflammatory effects, may something similar also appear in COVID-19 vaccination? Again, this is pure hypothesis, but do you think that these effects are restricted to flu shots, or may they also occur in other kinds of vaccination?
I think there's something special with influenza and influenza vaccine, and the cardiovascular complications we see with COVID-19 are different. So it's mostly in the direction of heart failure and deep venous thrombosis, and also these microclots everywhere, and this coagulation disturbances. But myocardial infarction, I think perhaps I've seen there is a small increase with COVID-19, but it's not a huge effect. So I don't expect such an effect with that vaccine.
I have a further question. What do you think about adjuvanted vaccines?
I don't know enough. I simply know that our inactivated vaccine is the most tested. It's been in use more or less the same formula since 1968. And 2 billion doses are distributed each year. There are data demonstrating that adjuvanted vaccines may be more potent, protecting against influenza, but I think a study is needed to show if it does the same.
Yeah, my idea was the cytokine expression is much higher with the adjuvanted vaccine.
Yeah. What we learn again and again in cardiology is everything we predict doesn't hold. Now we have, I think, 5 heart failure drugs, and none of these drugs were conceived as heart failure drugs. And you're probably also familiar with the new class of SGLT2 inhibitors. Nobody knew in their wildest imagination that this would be a heart failure drug one day. And now people thought, oh, you need that. Yes, of course, but we didn't know that when we introduced it. So there's, unfortunately, so often this gap between theory and the fact, and that's why we need to do trials.
So if there are no further questions, my wife asked me to ask you one question because she's both a fan of Nordic countries and of wild animals. And when looking at your homepage and your Twitter account on YouTube, we found that you are interested in research in wild bears. So you must, in the end, please tell us a little bit about this idea, which goes wildly away from vaccination, but which is so interesting, at least to us, that I would be really keen to hear a little bit about it.
I think my overall research philosophy is I'm curious and I try to do translational research within or without an area. And bears, brown bears are interesting because they sleep or hibernate 6 months every year. And as you know, our way of living is not healthy to us, but they can lie still. When they go into the den, when they hibernate, they are obese. And then they lie there for half a year. They don't eat or drink, and they don't pee or defecate, and they have no organ damage. And that's why this is such an interesting model. And we've done this research for 11 years now. We've found so many things, but we don't have the magic bullet. Why? We have some clues, and one molecule we singled out. We know now, no, that's not it. It's probably more than just one little thing, but it's very interesting. And there are too many studies on rodents, mice and rats, and you know how these studies can be translated to humans, often very poorly. So we need new models. This will provide a Nobel Prize, I'm quite sure, not to me, but to someone else later.
So you do the research by yourself, or how do you dig into this?
No, when I came to Sweden, I just, because I loved bears, I'm from Denmark. I came to Sweden, said, wow, I'm the country of bears. And I asked my boss, is okay, I do a little research on bears? Of course, she said, there are plenty here. And then it occurred that there was a biology project running in Sweden. And I contacted them and wrote a very, very serious synopsis. And they were interested and said, but they said, we haven't done it. We've never gone in to a bear while it was sleeping or hibernating in winter. So just to get the permission was some hurdle. And then the first years were difficult because we need to establish routines. But of course, we try to disturb the animals as little as possible, but they wake up when we come. So we sedate them with a dart. And then we take our blood samples, muscle biopsies and fatty biopsies, and then we put the bear back in, and then we find the same bear again in summer from helicopter. Of course, it's also quite spectacular and funny to do this research, and inspiring to work with a lot of specialties because so many different people with different skills are needed to make it work.
This is just fascinating, and one day we would be happy to discuss the results with you in a separate video, because I think you are probably the only researcher in the world who is interested in both very, very small living beings, if viruses are living beings actually, and in very large one like brown bears. So this is the whole spectrum of life on Earth, isn't it?
But then I will need 2 hours of your time, Gunnar.
We would be happy to share them with you. So thanks a lot for doing this fantastic study, and I'm again positive that this may really help us to convince more patients and maybe even our colleagues, both as doctors and as nurses, to go for their flu shot this year. Have a nice evening in Sweden. And when I looked at the map where Örebro would be found, so to be honest, I didn't know that city before. It's right between Gothenburg and Stockholm. I saw it's on the side of a very large lake, and it looks just fantastic when you look at the map. So I guess you would have a brilliant evening. So thanks a lot for taking the time, and hopefully seeing you some other day talking about brown bears. Thank you, Ole.
Thank you.